Hi, I'm Dr. Melissa Follett Caldwell. I'm one of your assistant medical directors, and we're going to talk very briefly about managing respiratory distress in a patient with a tracheostomy. So when you first encounter a patient in respiratory distress who has a trach, the first thing I want you to do is place supplemental oxygen on their nose and mouth. So this is either a non-rebreather, or this is going to be, you're going to bag them if it's clinically indicated. This is because most of the time it will be just a simple trach, plus you're about to monkey around with this. And so putting oxygen on this, you're just going to have to move it. So the first thing that I do, if they have the inner cannula in place, is I'm just going to pop that out, okay? So if this solves your problem, great. Most things aren't usually this simple, but if it is, this can just be unobstructed by pushing a bougie through it, rinsing it with warm water, or suctioning it. If that does not solve the problem, now you're left with just the outer cannula in place. And so you are going to aggressively suction, right? And you feel comfortable going pretty deep because you want to get as much out as you can. Another way you can suction is taking the inner cannula and putting it on the end of your suction, and now that will fit in. So that's a nice way to get a bigger diameter suction in, or ask the patient if they have suction equipment that will work, and you can use that. So aside from aggressively suctioning, you can also pass a bougie through it to try to relieve any mechanical obstruction that exists. You can also flush, and people feel a little uncomfortable doing this because we do know this is going to go right into their lungs if we're not careful. But I want you to try 1 to 2 cc's, no more than 3, and at the same time, I want you to have your suction equipment ready. So you're never going to do this without suction, but you're going to put your 1 to 2 cc's in, maybe 3, and they're going to make a bunch of noise. It's going to seem wet and a little scary, but then you're going to follow it immediately with your suction, okay? And the point of this is to loosen any dry, crusted secretions, okay? Also, if your patient's able, throughout all of this, encouraging them to cough, to break up and mobilize these secretions is very helpful, potentially. And also, if they're coughing while you're flushing, that will help protect the lungs and the lower airways. It's worth mentioning that there are 2 types of anatomy that you may encounter in these patients that have a tracheostomy. One is a simple trach, or just a trach that connects to the normal upper airway anatomy in a patient. So these are patients that can get intubated, be provided with supplemental oxygen, and get bagged from above as well. You have 2 points of access for their airway. But there is such a thing as a laryngectomy. These are much more rare, and you won't encounter them as often. But in this patient, the trachea, has been severed and brought forward and sewn into the stoma. And then the larynx removed, and the upper airway is now just a blind pouch. And this is relevant because you can no longer access the lungs through the nose and mouth. All right, thank you for watching our video about how to manage respiratory distress with a trach. If you have any other questions or any feedback for us, please do let us know, and we'll see you in the next video.